Welcome everyone to the Congenital Titinopathy webinar with Dr. Emily Oates. I want to thank you for joining us today. Dr. Oates is a pediatrician and clinical geneticist. But make sure I have that right. And can you please make sure to tell us more about that? And you can introduce yourself. But what I would really want to, how I really want to introduce Dr. Oates is that I know that she's really passionate about Titin and Titin-related muscle disorders, and that she has spent a lot of time, years, in fact, trying to gather important clinical information for the most recent paper on titinopathies, and just extremely grateful to have an amazing clinician like her, really attentive and caring about an important issue. That's an issue that's important to us, which is Titin. So with that, I'm going to turn it over to Dr. Oates. We had kind of thought that if you have a pressing question about a slide that's up or an existing topic that you could ask a question, you can post a question in the chat box. And also, if you would mute yourself when you're not speaking, of course not Emily, but listeners, you can mute your phone. And then I also wanted to just mention that this session is being recorded. So if you're sharing personal health information, that would be part of the recording. So you might want to use, you can leave, it's totally up to you on how you want to address that. And then we will have time for questions at the end. So with that, I'm going to ask Emily to tell us more about herself.
Okay, thanks, Sarah. It was a really nice introduction. So I'm from Australia. You'll probably be able to hear my accent. So I apologise in advance if some of my words sound a bit unusual. So the focus of the talk today is actually going to be the congenital form of titinopathy. So onset of this condition is during pregnancy or during very early childhood, so mainly infancy. And I've been at 3 different universities during the course of this project. As Sarah mentioned, it took many years for us to get that most recent paper together. And so I'm going to mention the affiliations with University of Sydney, UCL in London, with Francesco Montoni, and now back at UNSW University, so the University of New South Wales, which is also in Sydney. And I also want to say right at the outset that none of this work could be possible without patients and families contributing their data and being happy to be involved in our research. So thank you in advance for all of your contributions. And in fact, I know some of your families are included in this paper, so I thank you for that. So as Sarah mentioned, I am a clinical geneticist and a pediatrician. So in Australia, the general route to becoming a clinical geneticist is that you do pediatrics or adult physician training first, and then you subspecialise as a clinical geneticist, much like you might subspecialise as a pediatric neurologist. But I've also got a massive interest in research. I've done research for the last 20 years and in genetics. So I fell in love with genetics about 25 years ago. And I'm now a research team leader at UNSW. So lots of opportunities there for doing more research, particularly Titin research. And I just wanted to introduce you to my beautiful place that I grew up just before I started, Sydney. It's a beautiful blue sky morning here, and it's summer. So it's a little bit different to where you are, I suspect, at the moment. And I also popped in a couple of extra pictures of some of my travels within Australia just to show you how beautiful it is. The bottom 3 shots are actually from my family's farm in Orange in New South Wales, which is now a vineyard. So by way of talk outline, there's going to be 3 sections to this talk. So part 1, an introduction to Titin. What is Titin? I'm actually going to introduce you to the concept of isoforms because that's going to come up quite a bit in the talk. It's a bit of a tricky concept, but really important in terms of Titin. The different sorts of titinopathy, so the different sorts of conditions that are caused by mutations in this enormous gene, and then focusing particularly on congenital titinopathy, which was the subject of our recent paper. And then I'll talk you through the results of our cohort study. Many of you I know have already read it, so this is really just a summary of that. And then what I really wanted to do also was introduce you to what's going on in terms of research at the moment, particularly the research that I'm involved with, which I think is really exciting, and that I think you can probably contribute to as well. So this is a picture that will come up a little bit. It's what summer in Australia is like for some people, and it's just a bit of eye candy, really. So by way of introduction to Titin, Titin's a really key sarcomeric protein. and it encodes, the gene that encodes it is actually encodes the largest human protein, and in fact it's the largest protein in nature. And that poses many challenges for us, and it's also partly one of the reasons why it's taken us so long to realise that it's such a common cause of disease. In striated muscle, so when we talk about striated muscle, it's stripy muscle because it's got sarcomeres, and in general that's cardiac and skeletal muscle. In that sort of muscle, two molecules of titin align head to head to span the full length of the sarcomere. And this is a picture modified from Elizabeth McNally's really beautiful paper in Nature. Titin shown with the blue arrows. The Z lines on either side are the things that come together during a muscle contraction and then move further apart when the muscle relaxes, whereas the M line stays steady in the middle. And that's the basis of muscle contraction. And it's the myosin and actin in that diagram that drive that pulling. But what titin does is acts as a spring to modulate the integrity of that sarcomere during contraction, and also the elasticity, the rebound during relaxation. And titin's also got a number of other roles. It's a really important signaling hub. It interacts with numerous other proteins, and it's also a sensing hub. So it senses differences within the muscle in terms of mechanical properties, and that helps it do its job really well. So I am going to talk to you about protein isoforms now. It's a bit of a tricky concept, but I've used an analogy that I hope will work. And it's also, it's also an analogy we use with patients quite a bit as well. Oh, what's happened there? Can you still see my screen?
Yes.
Great. Okay.
Yes, we can still. There we go.
Okay. So there are different sorts of genes within the genome, but protein encoding genes are a particular subset of those genes. And what they do is generate an RNA protein recipe. It's called an RNA transcript for a particular protein. And I'm going to use a very seasonal example, so a Christmas pudding recipe kind of as an example of that. And each recipe, so each RNA transcript, is made up of multiple components, which are called exons, and these are effectively like the recipe ingredients, like the currants or sultanas in a pudding. Many genes actually encode a range of different protein isoforms, so they're slightly different recipe results. And these are generated by the differential splicing of their exons, so they use slightly different ingredients to make up that final result. So an isoform is isoforms are slightly different outcomes from that gene transcript. Now, our current understanding of the transcribed isoform content of human muscle is actually really limited. We don't really know very much about this. But what we do know is that there are several different titin isoforms. In human, actually at the moment, there's only one characterized skeletal muscle isoform, and it's called N2A. So that's going to pop up a couple of times during our talk today. And that was originally an isoform that was identified in a muscle called the soleus muscle, so one particular muscle subtype. And the two longest and most abundant cardiac isoforms are expressed in heart are called N2BA and N2B, and those labels are going to come up again and again in our talk, so that's why I'm bringing those up now. But there are also several other much smaller, less abundant cardiac isoforms that we know about, and there are almost definitely yet to be identified skeletal isoforms in other muscles and in developing muscle that we don't yet know about. So that's got important implications in terms of titin disease, and we'll talk about that a little bit later as well. And this is just a picture that will come up again and again in this talk. So the complete titin metatranscript is basically all the code that we know encodes titin. And this is a picture of the titin skeletal isoform, N2A, and the grey bits in that are the bits that are missing in that particular isoform in terms of the code. So those parts of the recipe are actually missing. And these are the two most abundant and longest cardiac isoforms, N2BA and N2B. And you can see that N2B is actually missing quite a big chunk here in the I band, but N2BA is missing much less. So those are the different those are the main isoforms we'll be talking about during the course of this talk today. Different isoforms actually have different amounts of springiness for titin. And in animal studies, the less mature muscle isoforms, so muscle isoforms that are present in maybe fetal muscle or neonatal muscle, are generally much longer, and they have additional exons, so additional recipe ingredients. And these are particularly exons that encode the PEVK I band region. So that's just a particular name for a subset of the I band. And that particular region seems to be really important in terms of the springiness of this molecule. So these longer, less mature muscle isoforms tend to be more springy and less stiff. So that seems to be something that's necessary for developing muscle, whereas more mature isoforms tend to be shorter and more stiff. So that seems to be really important for the function of a muscle when it's a mature muscle. And this is work done by Cohen Ottenheim, who's now based in Amsterdam, and also Henk Granzier, who works really closely with us and did a lot of the protein work for our paper. So mutations in titin, we now know, cause a whole range of different cardiac and skeletal muscle disorders. And we know that now because the massive advances in sequencing that have happened in the last 8 years or so have really opened the door to us being able to analyze titin for mutations. Before that, the gene was just too long to be able to do that well. All of the different titinopathies vary in terms of age onset and the clinical features. And this is a summary I put together for a recent grant that is an overview of some of the well-characterized forms of titinopathy. And it's divided into the dominant titinopathies. So these are conditions that are caused by mutations in just one copy of the 2 copies of titin that we all have in each of our cells. And recessive titinopathies. So these are conditions that you need 2 mutations on the 2 separate copies of our titin gene. So tibial muscular dystrophy, the Oates condition, so that's a condition that he first described many, many years ago as an adult onset disorder. And this is generally caused by a subset of mutations within the final 6 titin exons, so the M-band exons. And these were identified when sequencing of just that M-band was possible. And that has quite a different presentation to the other titinopathies for reasons that we don't particularly understand. And the limb-girdle recessive condition that you can see on the other side of that table is a particular condition that's caused by inheritance of 2 tibial muscular dystrophy mutations. So in consanguineous families, we see that coming up a couple of times in the literature. The next form of dominant titinopathy is hereditary myopathy with early respiratory failure, and because it's such a mouthful, people generally refer to that as HMIRF. And this is also an adult onset disorder, and it's caused exclusively by mutations in one particular exon, so one particular part of the recipe, exon 344, and they're generally missense mutations, so things that change the amino acid content of that protein, just one amino acid. And the reason why that's the case, we don't really know. Dilated cardiomyopathy is an interesting one. So in recent years, we've discovered that heterozygous, so single mutations, and truncating mutations, so mutations that cause a stop of the reading of the recipe. So these are things like stop mutations and frame shift mutations. So basically they chop off the end of the recipe too early. These are actually the most common genetic cause of adult onset dilated cardiomyopathy in the population. So that's been a really interesting discovery, and it's partly the reason why it's sort of given us a lot of lead into understanding the cardiac features of congenital titinopathy, this research area. In terms of the recessive conditions, we talked about limb-girdle muscular dystrophy, so 2J, so homozygous inheritance of 2 tibial muscular dystrophy mutations, a bit of a tricky subset. Recessive distal titinopathy, so that onset is childhood to adult onset, so a bit later than our congenital titinopathy cases. And then a childhood juvenile onset Emery-Dreifuss-like titinopathy. So it's not clear yet whether or not these are truly distinct disorders, but in the literature at the moment they are. And then, of course, there's congenital titinopathy, and that's a label that we started using in that paper to kind of describe that subset of cases that have onset either during pregnancy or during the infant period, because I think those are actually a particular subset of this condition. The reason for the differences in clinical onset and features are really not clear, but we suspect that they may, at least in part, be due to different isoforms impacted by different mutations. So I think mutations that impact so we'll talk about that a little bit later, but that's the same diagram that we discussed earlier. So congenital titinopathy, let's focus on that for a little while. So this is a condition caused by inheritance of 2 mutations, one on each copy of the titin gene that we have in our cells. So we have 2 copies in each cell. And the first couple of papers to describe this condition, and the condition was described under other titles in these 3 papers, like centronuclear myopathy. But these are basically the first 3 papers that describe this condition under separate labels. And the 3 papers include 14 cases from 11 families. The onset was always congenital, so at birth, often prenatal onset actually, or infant onset. All of these papers described children with respiratory and spinal complications being really common cardiac abnormalities. And that was interesting because some of them were actually congenital, and that's a really unusual feature for muscle conditions. And on muscle biopsy, we saw increased internalized nuclei. So normally the nuclei in a muscle fiber are around the periphery, but these were abnormally placed internally within the muscle, and I'll show some pictures of that later. In fact, I'll show you some pictures of that now. So you can see here that the nuclei are actually within the center of the fiber rather than the periphery. And or mini cores. So these are sort of punched out areas of the fiber, and I've got some photos of that later. So challenges in this area. At the start of this project, at the start of this paper, we had a really limited number of cases described, just those 14 cases. So that meant that we had a reasonably limited understanding of the diagnostically useful features, those features that are hooks for clinical people like me to kind of think about Titin, start thinking about Titin as a possible diagnosis. And also we had a limited understanding of the clinically significant complications that might develop in our patients over time. And we also didn't really know the range of severity, how severe or not severe the condition could be, and the natural history. So that's a term we use when we're describing progression over time, how rapidly it might progress. And because of its absolutely enormous size, there are naturally numerous normal variants, so slight changes in the spelling of the recipes within Titin. And almost every single one of us has one or more polymorphisms within this gene. So that makes it really tricky. It's really difficult to differentiate between true disease-causing mutations and just normal variations in the spelling of this particular gene. So that was the start of our cohort study. So the aims of this study were to establish the really common and clinically significant features of this condition in cases with the most likely to be pathogenic subset of mutations. And we wanted to do this in order to facilitate counselling and complication surveillance for our families, and also facilitate something called clinical fit assessment. So when we're looking at changes in Titin, looking at the patient's clinical features and seeing whether or not our patients have a good clinical fit for this condition, which is really important when we're establishing a diagnosis. And in terms of methods, we had a more than 70 member team of international collaborators. We were very, very lucky with how generous collaborators from around the world were in terms of donating cases to this project. And in the end, I think that paper had 84 authors. And we stuck to cases that had 2 recessives, so each copy of the gene had a change, but we only looked at cases that had 2 nonsense frameshift or essential splice site mutations in trans. So what that means is that the mutations either caused an early stoppage of the recipe, so the end of the recipe was lost, or an essential splice site mutation is something that affects the way the recipe is knitted together in the RNA. And when we talk about in trans, that means that it's definitely in 2 copies, the 2 different copies of the gene. And the way that we usually work that out is by sequencing the parents and seeing whether or not each of the changes that we found in the patient are present singly, so 1 copy only in each parent, which is why parental studies are so important. And in each case that we had, we scored for over 90 clinical muscle pathology and imaging features, so it was a pretty comprehensive analysis. And in terms of the cohort that we collected, and again, you know, we could not have done this without the generosity of families and multiple clinicians from around the world. So we ended up with 30 affected individuals from 27 families. And I think because we were so selective in the mutations that we were looking at, we were incredibly lucky to get so many families in this particular paper. We had 10 females and 20 males, and we don't really understand why we got so many males. And 3 families had 3 affected sibling pairs. And 2 were consanguineous families who had the same mutation, 1 inherited from each parent because they were related by blood as well as by partnership. And the ancestry was diverse, these cases from absolutely all over the world. 25 of the cohort members were living at the time that we wrote the paper. And these living individuals were aged 9 months to 34 years. And there was actually a reasonably good spread of ages, although I'll note here that the 18 years or older group was relatively small. So I think we didn't capture too much information about what surviving adults, what sort of problems they might have or how well they're doing. And some of them are actually doing quite well. So 4 patients were actually deceased at the time that we first became aware of the case, so at ascertainment, and 1 actually died during the course of the study, and that was a very unexpected and sad death. And the cause of death, which is important for us to know because preventing this complication is what we definitely want to do, was early respiratory failure. So 2 patients died, 1 at birth and 1 at just 3 months of age because their respiratory muscles were just too weak to enable them to breathe. And 1 died a sudden death at age 8, and she had a history of dilated cardiomyopathy, which was only mild to moderate in severity, but we suspect that she then developed an arrhythmia, so an abnormal heart rhythm, and that was the cause of death. 1 13-year-old died of pneumonia, and then another much older individual died of bowel cancer, and we think that that was probably an unrelated and really unlucky additional complication for him, so probably unrelated to his titinopathy diagnosis. What we found, so the common clinical features, so these are features that are present in 50% or more cases, and so give us a really good idea of what this condition presents like and how it progresses over time. And when the percentages that I'm about to show are actually the percentage of cases for which data was provided. So if we had 25 cases for which data was provided for that item and we had 21, the percentage would be 21 over 25 converted to a percentage, if that makes sense. So reduced fetal movements were incredibly common. Almost 60% of cases had that as a feature, and possibly that's an even more common feature. A lot of these pregnancies were first-time pregnancies for the mum, and so detecting reduced fetal movements in that instance is really hard for the mum to know whether or not that's a reduction compared to normal. In terms of the congenital features, so the features that are present at birth, congenital hypertonia, so really low tone, basically floppiness, and muscle weakness, so weakness of muscle movements, were present in 70% of cases. And in the other cases, the weakness usually developed within the first few months of life. The congenital limb contractures, so contractures in the fixed deformities of the limbs, usually the legs or the hands or the arms. They could be distal or proximal. So distal means feet and hands. Proximal is sort of knees and hips, elbows and shoulders. Those were present in 61% of cases. So they're actually really common. And there's a particular condition called, complicated name, arthrogryposis multiplex congenita, but that basically just describes children who are born with contractures involving 2 or more areas. So if you've got contractures of the feet and of the knees, then that would be the diagnosis, the descriptive diagnosis that you would get. And that was present in at least 43% of cases. I suspect it was actually more, but the ones that we were definite about were 43%. And this little baby has some of those features. So this is actually an Australian baby that I know about know a great deal about, and she's quite floppy. You can see that by sort of her frog leg positioning there. She's also got some contractures, and she's also got some feeding issues. We'll talk about that a little bit later. And this is another Australian baby who's got multiple contractures, particularly hand contractures and foot contractures. So distal contractures are actually quite a common feature of this condition. In terms of limb weakness, so we scored severity on the most severe muscle group, so the most severely affected muscle group in each patient, and that which muscle that was varied quite a lot. But the severity was generally mild to moderate, so 81% of individuals kind of scored in that range. And the most common pattern of involvement was proximal predominant, so weakest in the limb muscles that are closest to the body, so the hips and shoulders, but usually both the upper limbs, so the arms, and the legs, the lower limbs, are affected. Although in about 32% of cases, the weakness was asymmetrical, so the right and left degree of weakness was different. And non-congenital acquired contractures, so contractures that weren't present at birth but developed over time, were actually really common as well. So that's important for us to know in terms of managing cases, so 67%. This individual, again, is an Australian case that I know quite well. and he's quite an extreme case. And he's got a really good demonstration of contractures of his arms. And he's a case I'm going to talk about a little bit later, because he's taught us a lot about this condition and about how to manage it during the early stages. And I wanted to bring him up specifically because there are pictures of him in the paper, and I wanted to give you context to his clinical background. In terms of the facial features, so absence of ophthalmoplegia. So ophthalmoplegia is weakness of eye movements. And that's actually a really common feature in a whole lot of other conditions that cause internalized nuclei. So the absence of that feature in these cases is actually a really good hook for us in terms of thinking about this diagnosis. And in 100% of cases for which we had data on this item, there was no weakness of eye muscle movements. Facial weakness was also really common, as was a high arched palate. And the high arched palate normally develops because the facial weakness has been present during development in utero. So another really common feature. And these are pictures of another feature, ptosis. So you can see that the pupil in picture E of that little boy is partly covered, and that's a sign of floppiness of the eyelids. And I'm not sure that it's really easy to see in picture F, but this little boy is having lots of trouble closing and hiding his eyelashes because he's got a degree of facial weakness. In terms of motor ability, and that's really important for families to know about, in actual fact, 70% of our cases actually were currently still able to, or previously had been able to walk. So that's a really high rate and really important for us to know. And in fact, 11% more cases were actually still really young, less than 5, and were still gaining motor skills. So they were predicted to probably walk within the next couple of years, if not sooner. And in general, the patients who were experiencing a progression in their condition were experiencing a slow progression over time, or actually were stable in terms of their muscle weakness and had been for a while. So 50% of cases are in that category. And that, again, is important for us to know in terms of managing these cases. In terms of what we call axial involvement, so that's involvement of the central part of the body, so really the neck and the spine, neck flexion weakness was present in almost everybody. And that, again, is a really important feature because that's not present in some other muscle disorders. And neck extension weakness was also present in numerous cases. So by flexion, it's when you bend your head forward onto your chest, and extension is bending your head back towards your back. So weakness of both movements was really common. And scoliosis, which you may know about, which is sort of a deformity of the spine that generally happens over time, was present in 60% of cases. And that's usually present, that's present because there's weakness of the muscles around the spinal column that are unable to hold the spine up in the normal position. And that typically in the cases that we had was early onset and progressive over time. So that was important for us to know as well. This is the same individual that I showed in the previous diagram. It's a really severe version of scoliosis. And I think if I was a parent with a child, I would find this image a little bit scary. But to give it context, this man is actually doing incredibly well, and he's got the most amazing family. The reason why the scoliosis is so severe is that when he actually presented at age about 10 with a cardiorespiratory arrest. And so his scoliosis at that stage was quite severe and needed spinal surgery. But because his respiratory status had deteriorated so rapidly in early childhood, he actually wasn't safe for an anaesthetic, and so could never have his scoliosis fixed. We now know that respiratory involvement is really common in this disorder, and that we need to monitor that and scoliosis really intensively, particularly during early childhood, because if scoliosis is detected, you can actually manage that. And what you want to do is be able to manage that before the respiratory complications, if present, or if going to be present, become too severe. So that's been something that we've learnt about from cases like this one. And as an added, I haven't met this family, but I know the clinician that looks after this family and has been looking after them for years. They had 2 affected sons, both of whom did what many Australians do when they were in their early 20s. And despite their difficulties because of their titinopathy, and we didn't have a diagnosis for them at that stage, they actually went backpacking around Europe. They did need nighttime ventilation, but they put their their machines in their backpacks and they took off and went around Europe. So an absolutely incredible family and an incredible story. So this individual, as I mentioned, had an early respiratory arrest because his respiratory status had deteriorated over time and much more quickly than expected. So 63% of the patient cohort had some sort of objective evidence of early or late respiratory insufficiency, so weren't breathing as well as they should. And 44%, so almost half, needed some sort of nocturnal or full-time ventilation. That's really important for us to know, and if we pick it up early, we can manage it better. Joint hypermobility, that was a really unexpected finding. So that basically means bendiness of the fingers and the toes and the joints more than you would expect. And that's a picture of some bendiness in one of our patients. So I don't know why this is so common in congenital titinopathy, but it is really common. And it's actually a really good hook for us clinically. And really important to know also is that there's a lack of cognitive involvement in almost everyone. There's just one family with 2 boys who have very mild cognitive impairment, and that may be unrelated to this condition. And the CK, so that's the creatine kinase level that we often measure and can be high in some forms of muscular dystrophy. That's usually normal in this particular condition. And the highest level we've measured is at just over 2,000. But only 3 are actually above the normal range. So usually the CK is normal. And again, that's useful for us to know diagnostically. So the less common but really clinically significant features, I'm just going to give 2 examples here. The cardiac features are really important in this condition. So almost half had 1 or more cardiac abnormalities. And these could be congenital. So that, again, is really unusual in muscle conditions, skeletal muscle conditions. And I think when you see that in a patient, we now really do think about Titin. And there were different sorts of cardiac abnormalities. I won't go through each of these, but basically they could affect the valves of the heart, or they could affect the walls. So the septal defects are defects within the wall, within either the ventricles or the atria. But we could also see some other really significant complications involving the main vessels leading out of the heart as well. So 31%, so just under a third, had a congenital cardiac abnormality of some sort. And not all of these were severe. Some of them were severe and needed surgery. Some of them resolved over time. And in terms of non-congenital cardiac abnormalities, we included things like early onset dilated cardiomyopathy and left ventricular dysfunctions or hypercontractility. That just means that the big left ventricle that's responsible for pumping blood out to the rest of the body wasn't contracting in the normal way. And just under 20% of cases at the time we did this study had that as a feature. And that's important to know because, again, cardiomyopathy can often be managed very effectively if picked up early, but we have seen several cases that have actually developed very quickly and progressed rapidly over time. So at least we now know that that's something that we need to look out for in our patients. And the other thing is feeding difficulties. So many, many infants had feeding difficulties, but in actual fact, almost 40% had ongoing feeding difficulties after infancy. So I don't think that was something that we'd really appreciated at the beginning of this study, but it has a big impact on patient management, of course. And that was the only picture I could think of to put in for that, but that was a common feature. So this was a statement that my old PhD boss, Nigel Clark, the amazing Nigel Clark, used to say about Titin before we published this paper, and he used to call it the pathological chameleon because it could present in so many ways in terms of the muscle features. And I think that's a really good way of remembering the features of this disorder in terms of the muscle. So you can have centralized nuclei. So you can see in this picture that, again, the nuclei are internalized, but not only are they internalized, they're almost geographically within the center of the fiber. And that's a common feature of this disorder in some patients. Or you can have just internalized nuclei, so nuclei that are within the fiber, so abnormally placed, but not within the geographical center of the fiber. And in some cases like this one, we get a mixture of central and just internalized nuclei. And in general, what happens over time in people that have had sequential biopsies that have this feature is that the nuclei start in the center and then seem to drift out to the periphery over time in older muscle for reasons that we don't fully understand. This is an EM picture, so a really high-powered picture of muscle that shows mini cores. And these are these centrally sort of punched out areas of the muscle fibres, and they're quite a striking feature in a subset of the muscle biopsies that we have in our patient cohort. And sometimes they were centrally placed, so they looked a little bit like the central cores that we see in some other muscle conditions. But in fact, the other features of a typical central core weren't really there. So in actual fact, we think that they just happened to be centrally placed mini cores, probably, but we're still learning about the muscle features. This is a particular feature called congenital fibre type disproportion. So it basically means the two main fibre types, type 1 and type 2, which are black and white in this picture, are very different in size. And if the percentage is of a particular, so if the difference between the sizes is over a particular percentage, then it actually scores this particular diagnosis if there are no additional features. So we had one patient that just presented with this as the muscle features, muscle features. We also had cap-like structures. We didn't have enough features to know whether or not they were definite caps, but you can see in this picture that there were some pale purple areas within the fibres. I'm not sure if you can see my arrow. And these are caps, so collection of abnormal protein within the muscle fibres. And we saw that in a couple of patients. And also one of the most common features was fibre size variation, so just really big differences in the sizes of the fibres. You can see in the first image of this slide that the fibres are relatively uniform in size, but you can see here this is a more typical feature. You can see there's a big difference in the fibre sizes within that muscle biopsy. And in fact, there was quite variable amounts of fat and fibrosis. So in this particular picture, there's a whole lot of fat and fibrosis within this muscle. It looks very abnormal. But again, if you look at the first image in this slide, there's very little. So that was quite a variable feature. Sometimes there were signs of degeneration and regeneration, and those are signs that we often associate with a muscular dystrophy rather than a congenital myopathy. But when we did see that, it was never a particularly marked feature. Having said that, some of the muscle biopsies had been scored as a dystrophy rather than a myopathy, and that's important for us to keep in mind. If the muscle does look dystrophic to the pathologist, it doesn't always mean that titin isn't the diagnosis. And what we often saw was that we got combinations of features. So we often got internalized nuclei and cores, and sometimes even caps as well. And what tended to happen again in patients that had sequential biopsies, so more than one biopsy at different ages, is that the number of features tended to increase over time. So the nuclei that were in the wrong position became more peripheral, so internalized rather than centralized, and you got more additional features in the older biopsies. And we actually tried to graph the amount of overlap between our features. So each dot in this particular picture represents a muscle biopsy. And you can see that there was quite a lot of patient biopsies that had more than one feature. So fibre size variation, very common. Internalized nuclei and cores, also very common. And then other structural features like caps. In terms of the muscle MRI, so you may be aware that we increasingly use this as a diagnostic tool in the world of myopathy and dystrophy, and that's because the cross-sectional picture of muscle that we get, particularly when we do leg MRIs, the ones that we most commonly do, gives us an idea of what the diagnosis could be, because the pattern of involvement is often very specific for a particular gene. So the muscles that are spared and the muscles that are heavily involved tend to be the same in a particular genetic diagnosis. So we're really interested to know what the pattern was for titin. Unfortunately, we didn't have too many cases for this particular paper, but I know that others are working on a much more detailed publication that summarises this in more detail. So we had 3 cases that had reports or descriptions, and 1 case that we had definite imaging for. And then we had additional imaging for 1 case which we call segregation inconclusive. So we actually didn't have the parents to make sure that the 2 changes were definitely on the 2 different copies of titin rather than the same copy of the gene. But we're fairly sure that this case is actually a true congenital titinopathy case. And these are the pictures of the cases that we had images for. So the picture on the left is the case that is definite, and you can see that there's a little bit of white muscle in various locations within those cross-sectional images. So it's as if we've sort of cut the legs like pieces of spaghetti and we're having a look cross-sectionally. On the right is that segregation inconclusive case, which we think is actually a real case. And you can see there's a really specific pattern of involvement there that's not too similar. In fact, it just looks like a more severe version of the first case. And in general, what we saw in all of the descriptions and imaging was atrophy of a particular subset of muscles, so the paraspinal muscles, the muscles that support the spine, the gluteal muscles, so the buttock muscles, and the hamstring muscles. So those are the muscles at the back of the thighs. And in general, the adductors, so those are the internal thigh muscles, were spared. And in the lower leg, the posterior compartment, so that's really your calf compartment, tended to be involved, but how much involvement, so how much white tissue there was on the cross-sectional MRI was quite variable. Family history of cardiac involvement, so that's a really important, cardiac involvement is a really important part of this condition, both for affected individuals, but also for carriers of particularly truncating and splice site mutations. So we're going to talk a little bit about that now. So there was a definite history of dilated cardiomyopathy, so adult onset dilated cardiomyopathy in 2 families. In the first family, there was a mother, a maternal grandmother, and a maternal aunt with subclinical cardiomyopathy. So they didn't actually have any clinical symptoms as a result of that, but they definitely had a larger than normal heart. And all 3 were definite heterozygous carriers, in this case, of splice site mutations. And in the second family, we had a maternal aunt with the same feature. We're not quite sure whether or not she was a carrier, so we don't have access to her DNA to test. And there was also a history of congenital heart disease in an additional family. So we had a sibling of an affected child who had quite severe congenital heart disease. And the mutation status, again, of that sibling is unknown. But that makes us think that cardiac involvement is a real thing for carriers here. And that's not surprising when you think about the fact that truncating and splice site mutations in this gene, just one of those, is a really common cause of dilated cardiomyopathy in the general population, as we talked about before. But cardiac screening in our cohort was really incomplete. So that was a big confounder for this particular study. Only 19 parents of the 54 parents included in our study had actually had any sort of cardiac screening, and a much smaller subset of extended family members, including carrier siblings, had undergone cardiac screening. So we really don't have the complete picture yet in terms of the degree of risk for carriers of Titin mutations. But we did have a look at cardiac isoform involvement because of that pre-existing literature that we had in the dominant dilated cardiomyopathy literature. So these are the 3 papers that have published in this area. And these papers showed, again, heterozygous truncating, so mutations that chop off the end of the gene, the transcript, the RNA transcript, and essential splice site mutations, so that affect the knitting together of the exons, that impact the 2 most common cardiac isoforms, increase the risk of adult onset dilated cardiomyopathy. So again, that's the picture we looked at before, and the 2 yellow arrows show those 2 common cardiac isoforms. But patients that had truncating mutations that altered other isoforms, so fetal isoforms or the smaller, less abundant cardiac isoforms, were not associated with this complication. So that's really important for us to know as well. So looking at the impact of the mutation on the isoforms and which isoforms are affected seems to be really important. So what we did in our study is that we worked with one of the teams that had actually published in this area, James Ware at the Royal Brompton in London, and they did an analysis that suggested that individuals in our cohort that had 2 mutations that both affected both of the main cardiac isoforms were significantly more likely to have cardiac involvement, so either congenital cardiac involvement or early onset dilated cardiomyopathy, than those with other combinations of mutations. So that, I think, is really important for us to know in terms of managing our patients. We didn't have enough families to be sure about whether or not relatives with one of these mutations that impact the common cardiac isoforms are at the highest risk of developing adult onset dilated cardiomyopathy, but we do know that both the families that had a maternal history of that had a maternal mutation that did impact both of those cardiac isoforms. So I think the jury's still out about what that means for carriers, and at the moment we recommend screening of all carriers and regular follow-up screening as well, probably every 5 years, just to be sure, and just until we have a clearer picture of what's happening here. And I think once we've developed more cases that are confirmed, we collect more cases, we'll actually be able to do a more detailed analysis that will, I suspect, will confirm that that's a risk. An unexpected finding. So this is work by my close colleague, Mark Davis, who works in Perth. And he realised that 10 of the 30 patients in our cohort, so he did a lot of the mutation work and the mutation curation for our project. He did that extremely well. He realised that 10 of the patients had one mutation that impacted exons that were included in the complete script that we've been looking at it in a couple of images, but that did not impact exons that were included within the single skeletal muscle isoform that we knew about. So that was a little bit unexpected. And all of these mutations are in that PEVK region that we talked about before, and that's the region that often includes extra, so the young isoforms that are more springy often include extra exons from this particular region. And in actual fact, we had 5 unrelated cohort families that had exactly the same mutation. So that really made us think that this was truly a disease-causing mutation. And we needed to take these seriously. And in addition, we realised that a lot of the original transcript, the meta-transcript, had actually come from human fetal muscle. So that made us really suspicious that there are yet to be identified developmental isoforms, so fetal isoforms, that contribute to the pathology of this condition. And when you think that it's actually usually a condition that's present from birth or develops in very early infancy, that makes a lot of sense, that the fetal isoforms are involved in how this condition develops. And we actually did a subset analysis, and we looked at patients, those 10 patients that had those what we called non-2A mutations or meta-transcript only mutations. And these are some of the pictures of those patients. So very typical clinical features. What we realised was that respiratory involvement appeared to be less common, but we also realised that they were younger, so maybe they just hadn't developed their respiratory involvement yet. Okay. But cardiac involvement was also much less common, so only 1 of the 10 cases had any sort of cardiac involvement, and it was incredibly mild. And that makes sense when you realise that these mutations don't impact either of those 2 cardiac isoforms that we've been talking about, so that's interesting. And in actual fact, a number of my colleagues, including myself, have noticed that these patients don't seem to progress clinically over time in terms of their weakness either. So they seem to be behaving a little bit differently. So in summary, from this study, we found that congenital titinopathy causes early onset neck and truncal weakness, so spine, chest wall weakness without eye movement involvement. Scoliosis, respiratory involvement, and cardiac abnormalities are really common, and they're the things that we worry most about in our patients. We've got a good picture of what it looks like on MRI, and we know that there are a range of different muscle biopsy abnormalities. It looks like heterozygous carrier relatives, so relatives that have 1 copy of a mutation that causes congenital titinopathy, maybe at increased risk of cardiomyopathy, but we don't yet know the degree of risk. It's probably going to be highest for those with mutations that impact those 2 cardiac isoforms. The discovery of mutations in exons or parts of the recipe that don't include the skeletal transcripts suggests that there are lots of other isoforms involved, and we suspect that developmental isoforms are involved. But there's still a great deal about this disorder that we don't know, and there's still a great deal about titin muscle isoform biology that we don't yet know about. So, and this is just a list of the amazing group of collaborators that contributed to this project, and in particular, Christy Jones, Nigel Lang, and Mark Davis from Australia had a big input to this project, and those are some of the funding buddies that supported me. And I always put this slide in during any talk, so thank you to the patients and families who allowed us to include their data in this study. So thank you to all of you online who had patients who contributed data to this study. And part 3, so current research. This is hopefully really exciting stuff. What we now know but didn't know when we started this project was that it increasingly appears that congenital titinopathy is one of the most common forms of early onset muscle disease, one of the most common congenital myopathies. For example, it's actually the most common diagnosis made in early onset myopathy cases sent to my colleague Mark in Perth for his neuromuscular gene panel. So this is actually even more common than RYR1, which used to be his most common diagnosis. And in terms of our clinical project, so what we're doing at the moment, and you might be able to help me with this, is
Emily, I'm sorry to interrupt you. I'm sorry to interrupt you. This is Sarah. I just want to say, if you're on the call, if you're not speaking, if you could mute your phone or your computer so we can hear some background noise, and that way we can hear Emily perfectly. Thank you. Sorry to interrupt you. Go ahead.
That's okay, and we're coming to the end, I promise. It's taken a little bit longer than expected. So ongoing case collection. So you can definitely help me with this. What we're doing is ascertaining a large and therefore clinically informative cohort of patients. So basically, we're still collecting cases. And we want to do that to do additional cross-sectional analyses like our cohort studies, looking at a whole lot of features and getting a much better idea about those. And our goal was 100 cases, and we've currently got about 80 from around the world. So that's terrific. We've got lots of clinical papers underway. So there's a severe cases paper that describes the more severe end of this disorder, but we've got an adult survivor cases paper also that describes more mildly affected individuals that are doing quite well during adulthood. And we've also got a pathology paper that we're putting together with Carolyn Suri and Rahul Padki in London. We've got some planned papers. So we've got another paper that looks at those cases with non-N2A mutations. We now have many more of those cases. We've also got a patient and carrier cardiac risk paper that we want to do. And we also have an atypical cases paper, including a really informative patient from overseas who's actually not weak. She's got really convincing mutations. They're definitely on 2 copies of her, both in separate copies of her Titin gene, but she's actually not weak. And I think if we work out why she's not weak, that will be incredibly helpful for us in terms of working out future treatments. And there are lots of muscle projects too, patient muscle projects, trying to look at the impact of mutations at the RNA level, so how they affect transcripts, at the protein level, so how they affect the actual protein produced from the gene, and also at the single muscle fiber contractile level. So Henk Granzier does this amazing work, as does Cohen, where they actually take a single muscle fiber out of a frozen muscle biopsy and put it between forced transducers and look at the contractile properties of that fiber. So that's actually really important work in this area that we're planning to do. We've also got a big isoform project. So what we want to do is sequence, so look at the RNA transcript data from a whole lot of normal healthy skeletal muscle and cardiac samples, and to actually work out and characterize the yet to be identified isoforms that we know are there, but we just don't know much about. And to determine also if the mutations that impact the highly expressed isoforms at different times in development have the greatest clinical impact. So for instance, if you have a mutation that impacts a highly expressed fetal isoform, does that make it more likely that you have a more severe early presentation? And also we can actually use the same data set again and again to analyse other disease genes. So having that data set is really important, and it's the subject of a grant that I've been putting together in the last few weeks. And also I've been doing a Titin interactome project with a couple of my colleagues here at UNSW. So that's aimed at looking at lots of different database, protein-protein interaction databases, to pull together a list of all the known binding partners for Titin, and also to identify their binding sites within Titin. And that's to help us determine what the mutation impact might be for mutations, so what binding abnormalities might result from a mutation in a particular spot, but also to facilitate new disease gene discovery, because many Titin binding partners are actually disease-causing genes in their own right, and telethonin is a great example of that, TCAP. And that's the end of the story, and it's a huge mountain that we're climbing, but I'm hoping that we'll get there. And thank you once again for all of you who've contributed to the work that we've done so far, and hopefully you'll be happy to contribute moving forward as well. So yes, questions. That took a lot longer than expected. I apologise.
Emily, thank you so much. That's fantastic, and I really appreciate your commitment to herding over 80 collaborators from around the world to collect information on congenital titinopathies and spend a couple of years doing it to make sure that we could get this clinical important data that's really so critical to our family. So thank you so much.
That's okay. It was interesting editing the paper when I had feedback from about 50 different people all at once, but we couldn't have done that project without the input of so many people. So we were so lucky that so many people were generous with their data, both clinicians but patients as well. So thank you.
The last thing I would want to say is that we are recording this, so if you're asking questions, if you were talking about your personal health information, that would be part of the recording, but people are welcome. If you want to unmute yourself and you have some questions for Emily, you can open it up to questions. So I have one question here. Oh, go ahead.
Do you guys collaborate with, say, Dr. Bonneman at the NIH? We have a child that has a likely titinopathy. We finally got quartered this May, but it's clearly on a portion of titin that hasn't been finished mapping yet. And do you collaborate with other people that are trying to study the same thing?
Absolutely. So
we would love to know.
Yeah, so Carsten's group actually gave us multiple cases for this particular paper. They were incredibly generous in terms of their support. So yes, we do, and we aim to continue to do so as well. And many of the cases we share, so some teams decide to focus on one particular area and write up work in that particular area, and others focus in other areas. So it's very much a combined effort. So in terms of American investigator Henk Branzier, Carsten Bonneman and Alan Beggs, we work very closely with, and all have been very generous with their time for us.
Great.
Yeah.
Well, you can have our data if you want it.
Absolutely, that'd be great.
Both Dr. Beggs and Dr. Bonneman have our daughter's data, so you're welcome to it.
Yeah, thank you. That's terrific. Thank you.
So I have a question in the chat box, which is, what role have you seen physical therapy play in assisting children to improve?
Sorry, what role for physical therapy? Was that the question?
Yes. What role have you seen physical therapy play in assisting children to improve?
I work in the neuromuscular clinic out at the Children's Hospital at Westmead, so that's one of the big kids' hospitals in Sydney. And in fact, I'm going to be working in both kids' hospitals very soon. And we have a multidisciplinary clinic which relies very heavily on our allied health expertise. We've got some fantastic physios. And the physical therapy makes a big difference. So in particular, in terms of managing some of the contractures that develop over time, it's incredibly important. And our physios are also really good at detecting things that could become a problem over time as well. So I think it has an incredibly good supportive care is actually really critical for these patients, particularly at the moment where we don't have an effective treatment. And there were things in the future that might happen there, and I can talk about that as well, but physical therapy is incredibly important.
Oh, thank you. So this is Sarah, another question in the chat, which is that you mentioned the higher percentage in your paper was males in the sample. Is there reason to think that males are more affected overall, or that genders are affected in different ways?
That's a really interesting question. I think it was just an accident. I don't think that that's actually a thing. But I'm actually not completely sure. It was quite skewed, and I'm not really sure why that might be. We know that titin is part of a signaling hub, so it's involved in lots of signaling cascades. And whether or not one of those might be a hormonal cascade, it's not yet clear. But having said that, we didn't really collect patients on the basis of severity. We just collected them on the basis of mutations. So I think the answer to that is it was just by chance that we ended up with more males than females. But I think the jury is still out about whether or not there's a difference in terms of gender and progression over time. My gut feeling is that the type of mutation and its impact on which subset of isoforms has a bigger impact, but there may be some more subtle impacts. I'm just not sure. I think the jury is out.
Okay, thank you. And another question we have, are there adult onset titinopathies?
So there are definitely adult onset titinopathy. So if we think back to that table that we were looking at before, so tibial muscular dystrophy, that first form of titinopathy that Bjarne Oud originally described, I think back in the 80s, it was a long time ago. That's definitely generally an adult onset case, a few really atypical cases that present in teenage years, but generally adult onset. And that's a dominant condition caused by just one mutation in titin towards the end of the titin gene in that M band region. Many people consider the dilated cardiomyopathy you get from a subset of titin mutations as an adult onset titinopathy. And what was the other one? Oh, HMERF. So that long-winded name, HMERF, which is caused by mutations in exon 344, that's generally an adult onset disorder as well, although there are some earlier onset cases, and there are some cases where we suspect the features were there earlier than the time the patient presented. So yes, but generally they tend to be the dominant disorders, whereas the recessive disorders tend to be onset in childhood or at the latest adolescence. And that's something that we often see in dominant versus recessive disorders. If you have both genes impacted, then generally the condition presents earlier and is usually more severe.
Great. Okay, thank you. Just the next, at least two other questions here. One is in regards to respiratory. Have you seen anyone's respiratory status improve, or does it generally progress, getting worse?
So what I've seen is that respiratory status sometimes improves if there's an early decline and that good management is instituted. So sometimes what we see, we often look at things like forced vital capacity, so FVC, and when that drops below 80%, that's considered abnormal. What I have seen in a couple of patients, quite a few patients actually, is that when we see that initial drop-off below 80, when really good respiratory management is instituted, it can not always normalize, but it can actually improve slightly over time. So good respiratory management is really important. And again, we work quite closely with respiratory clinicians in our neuromuscular clinics. I think clinically it probably does worsen over time, although the jury's out about what those patients with the non-N2A mutations, what happens there. So in general, probably the respiratory muscles become weaker over time, although that can be a slow progression over time. And again, good respiratory management can really slow that progression, if not halt that progression. The other thing that often happens is if your respiratory muscles involved, it often happens that your spine is more likely to be involved. So it seems that the chest and the spinal, so basically the central part of your body, if one's involved, the other is often involved. So you often get scoliosis developing with respiratory impairment, like in that adult that I was talking about before. And the scoliosis is kind of a double whammy situation because the bending that you get with the scoliosis means that your lungs have less room to expand, and that impacts your respiratory status independently of your respiratory muscle weakness. So the two things together are not a great combo, but managing the two things has a big impact. So again, if you have scoliosis surgery, there can often be an initial improvement or certainly a halting of respiratory deterioration. So both those things, scoliosis management and respiratory management, are hugely important.
Okay, and the last question I have here in the chat box, there's more, is what's essentially the yardstick or determining factor that you use to determine if a patient's titinopathy is progressive or not?
That's really interesting. So normally at the moment that's a clinical call. So whether or not, I guess it's also an observational call. So many families will know whether or not their child is becoming worse over time and is having more complications. So sometimes it's really obvious that things are progressing, and in particular we had one family where a child that had been walking lost the ability to walk. That was relatively rare in our findings. There are other ways that we measure clinical progression, and we often use these techniques in clinical trials too to determine whether or not a treatment's effective. And those are things like 6-minute walk tests or myometry, which is a very specific machine that's calibrated to pick up small differences in muscle strength if used appropriately. So in some studies, for other conditions that I've been involved with, we've used myometry and things like the 6-minute walk test to determine whether or not we've had significant progression over time. But in terms of clinic to clinic, day-to-day management of patients, it's normally when we see them in clinic and something has changed since we last saw them. And for this particular study, we relied very heavily on just clinical descriptions from good clinicians to determine progression, and also self-report from families. And we defined slow progression as unlikely to impact walking ability for at least 20 years, moderate progression as probably will impact walking ability significantly after 10 years and rapid as earlier than that. So that's the first time that that particular definition has been used. We developed it for the study, and it's not particularly sensitive. I think over time we'll get better at measuring progression. And in fact, we need to get better at measuring progression if we are going to develop future treatments for this disorder. Hopefully that answers that question.
Thank you. And another question here is there a relationship between scoliosis and hypermobility or lack of mobility, hypermobility?
That's actually a really good question, and I've actually wondered that. Our problem is that scoliosis is really common and hypermobility is so common. It might be really hard to get enough cases to tease that out. Having said that, hypermobility generally affects limbs. So often you get more, so for instance, clinically, if you're very hypermobile or bendy in your fingers or your toes or your knees, you tend to get some orthopedic problems earlier than you would normally do. But you wouldn't normally expect the spine to be affected by that. So generally it's the peripheral joints of the limbs that are most impacted by that hypermobility. Having said that, people who are really hypermobile often find it very easy to bend over and touch their toes. And it's one of the measures of hypermobility that we look at clinically in other disorders that really cause big problems in terms of hypermobility, like Ehlers-Danlos syndrome. So I think that there's a chance that having this sort of connective tissue hypermobile joint thing going on might actually impact the scoliosis, but I think, again, the jury is out. It's a really good question. And I think, again, that's the power of having lots and lots of cases to look at. We can start to do statistical analyses to see whether or not there is a correlation between things that might be associated. So hopefully when we have our big and growing cohort, that is something that we can definitely look at. That's a long-winded response to that question.
Thank you. Okay, one more question here. Let's see. Someone in the group has a Titin heterozygous for a variant of unknown significance and hypertrophic cardiomyopathy with surgical intervention. And his son also has hypertrophic cardiomyopathy at age 13. Where would you suggest we start with a plan for helping him to slow or prevent level of muscle pain that the adult in this family is experiencing?
So there's kind of two questions in there. It's whether or not it's a true titinopathy, because it sounds like it's a variant of unknown significance, and then treatment of muscle pain as a problem that is shared by many different muscle disorders, and it's actually really troublesome for many patients. It's actually the most debilitating symptom. So I'm going to answer the second question first. So we actually often, in our management of muscle pain, we start with things like Panadol and Nurofen, but there are often reasons why continuing that long term is not ideal. We actually, when it becomes a really significant problem for our adults, and in particular I'm thinking of our adults with Becker muscular dystrophy, who are often parents of children that I manage in clinic, we sometimes refer to the pain clinic for management of their muscle pain. But it's actually a really troublesome symptom, and I don't think we have a good handle on it, what causes it, and also how to treat it really effectively. So it's a really good thing to bring up and notice. Hypertrophic cardiomyopathy is a bit different to dilated cardiomyopathy. So that's an interesting particular family. I'm working now quite closely with a couple of teams that work on cardiac Titin from a cardiac point of view, and there's actually a big team in Sydney here run by Diane Fatkin who's really interested in this area. Can't believe they're in Sydney, it's so good. What we could do is two things. We could actually get them to have a look at that particular variant of unknown significance, which I'm assuming is a missense change, but I may be wrong. And the other thing is that I've got a really close collaboration with Matthias Grotel, who works in London, and has developed a really nice pipeline to analyse missense changes in Titin. And he thinks that he's able to predict quite accurately by looking at all of the things that we know about Titin that he's integrated into his computer system, can more accurately predict whether or not a particular missense change could be just a polymorphism or could be disease causing. So there's two things we could potentially do there, and one is involve Diane Fatkin and just having a look at that variant, and also involve Matthias Gotel in terms of looking at that variant. But in general, what we see in titinopathies in terms of a heart condition is usually the dilated cardiomyopathy, which is sort of a different condition. But it's an interesting question, and I'm happy to help with that if that's helpful.
So I'll have this next question be the last question. Thank you for that. It's similar in the same vein as somebody with symptoms and a identified variant, they connect with you on a clinical level. And they said they're an NZ, which I'm guessing is New Zealand. I'm not sure. It's an abbreviation commonly from NZ. You dropped out a little bit there in those last few sentences. Oh, sorry, Sarah. Sorry. So I guess it's a similar question, is that someone's talking about their symptoms and wondering if they could connect with you on a clinical level.
Yeah, definitely.
So, and what would be the best way for them to reach you, Emily?
Best way is probably email, because of the time difference, if nothing else. So I should have put my email address at the beginning, but it's, I'll send that through to Sarah, and Sarah, can you send that out? I'm happy for you to send that out.
Yeah.
I would put a caveat on that. I get quite a few emails, so sometimes it takes me a little while to get through them all. And so I often have to prioritize. So I apologize in advance if it takes me a little while to answer your question. But what I usually am able to do, if I'm not able to answer the question myself, is to involve the collaborators that I've been working with. I've pretty much been able to work out answers to everything that's come my way so far, but I'm very, very happy to help. So via email, that's the best way.
Thank you so much. Thank you for taking the time to put this presentation together and all your work that you're doing on behalf of families affected with Titin and other muscle disorders. And just really, from the bottom of my heart, I really appreciate everything. So thank you for being with us today.
That's okay. I should actually say, if I am involved clinically with any patients, I generally CC in whoever clinically is working with them in their home, in their hometown or their home base, just so that everyone's kept in the loop in terms of, what's been said. It's been great, actually. I've seen a couple of names come up that I know very well and I know have been involved in my project. So I can't thank your group enough for what they've already contributed to the project that we've just published. And yeah, really keen to keep moving this area forward. So I'm really pleased that some patients and families might be happy to participate in our future projects. So I think that's really exciting.
Okay, I'm going to stop the recording. I'm going to just see if I can share my.
I think Pat in New Jersey has just emailed. He just said, "Is it that email?" Yes, it is that email. e.oates@unsw.edu.au.
Thank you, Patrick. And then let's see if you can see my screen. I just wanted to show. I have to make another plug for this, which is our Scientific Family Conference. This is going to be another opportunity for us to be with families, to talk to each other and ask questions and to connect with clinicians and researchers. I have already some commitments from some researchers. We're in the early days of scheduling this, so no formal invitations have gone out to clinicians, but we're just starting to get some basic hotel contracts and things, so please save the date, and I'd love to see all of you in Chicago this summer. It would be great. Okay, so thank you, everybody.
Yay. And thank you, Sarah, for organizing this.
Okay, good night.
Thank you, Sarah. Thank you. Thank you for presenting.
Thanks. Bye. Bye.